Okay, let's unpack this. When we're talking about medical triage, especially for something as potentially catastrophic as a pulmonary embolism,
Mm.
a PAE, the speed of decision-making is
It's everything.
it's everything. Time is oxygen, and a wrong turn can literally cost a life. Today, we're doing a deep dive into the system that guides those choices, the Wells score, and the management protocol that comes with it.
That's the core of it, really. For you, the learner, the goal here is to get past the acronyms and see why things happen in a certain order.
Right.
Our mission is to show how this scoring system takes a few clinical findings, gives them a number, and then, dictates the whole diagnostic and treatment path. That's a really efficient decision tree.
So it's not just a checklist. It's more like a clinical philosophy turned into points.
Exactly.
You're translating this vague patient distress into a structured risk. But before we get to the different paths, we have to understand the building blocks. How do you get those points, and why are some weighted so heavily?
That weighting is really the genius of the Wells score. It's designed to separate the highest risk patients from the lowest risk ones fast.
Okay, so if we look at the source material, the highest weighted factors, they're clocking in at 3.0 points each. That immediately tells you the suspicion is high.
Very high. These are profound findings.
Yeah.
The first one is getting 3.0 points for clear clinical signs of a deep vein thrombosis, a DVT.
And that's not just a slightly sore leg, right? We're talking objective evidence.
Exactly. Leg swelling, pain when you actually palpate it. This is huge because the DVT is the source of the clot that becomes the PE.
And the second 3-point factor, this one really seems to rely on clinical acumen. It's a judgment call.
It is. It's the assessment that an alternative diagnosis is less likely than a PE.
So you're basically saying, I've thought about pneumonia, a muscle strain, a rib fracture, and I'm still coming back to a clot.
Yes. And those 3.0 points for just ruling other things out, that's often the most important factor. The score forces you to stop and think, could this be something else? If the answer is no, the score jumps.
That makes perfect sense. What's the biggest pitfall there? It seems subjective.
It is subjective, and the biggest pitfall is overlap. So many things can mimic a PE. A panic attack gives you tachycardia. A rib fracture causes chest pain.
Right.
The trap is anchoring on the first diagnosis you think of. The strength of this requirement is that it forces you to think wider.
So it's a system designed to guard against diagnostic error.
Precisely. Now, moving down a bit, you have the 1.5-point factors. These tend to reflect patient history and current stress on the body.
Okay, so what falls into that category?
For instance, you get 1.5 points if the heart rate is over 100 beats per minute.
Which reflects the body trying to compensate for that obstruction, right? The heart is racing to push blood through.
Correct. We also give 1.5 points for immobilization, 3 or more days, or if they've had surgery in the last 4 weeks.
Classic triggers for blood pooling and clotting.
Exactly. And a previous history of DVT or PE. That automatically gets you 1.5 points.
Non-negotiable, I'd imagine. If you've clotted before, your risk is just higher.
Significantly higher. Then finally, you have the lower weighted factors, each worth 1.0 point. These are acute, but maybe a bit less specific.
Like coughing up blood, hemoptysis.
Yes, hemoptysis, which suggests some lung tissue damage. That's 1 point.
And the final point is for cancer, which we know creates a hypercoagulable state.
Right, malignancy. And it's defined pretty specifically. Active treatment, treated in the last 6 months, or palliative care. That adds 1 more point to the total.
So after you've tallied up all these 3s, 1.5s, and 1s, the final score tells you what to do next. I know traditionally it was broken into 3 categories.
Yeah, high, moderate, and low probability. And that's fine for understanding it academically, but the source material really pushes this alternative simplified version for managing patients quickly.
Because in an emergency, you need clarity.
You need a clear binary path. Is a PE likely, or is it unlikely?
And what's that pivot point in practice?
It's the score of 4. If your total is greater than 4, PE is likely. If it's 4 or less, it's unlikely. That simple number becomes the fork in the road.
Okay, let's go down path 1 first. High probability. Score is greater than 4. What's the immediate mandatory action?
The protocol says immediate diagnostic imaging. You go straight to a CT pulmonary angiography, a CTPA.
The gold standard. You inject dye and you get a direct look at the arteries.
Yep. High suspicion means you skip the intermediate steps and go right for the definitive test.
But there's a huge exception to that rule, isn't there?
A critical one.
Yeah.
And it really illustrates the kind of ruthless triage you need in emergency medicine. If that patient is hemodynamically unstable, you can't take the time for a CTPA.
And when you say hemodynamically unstable, for the learner, we're talking about a patient in shock. This is a massive PE.
We are. This isn't just low blood pressure. This is the clot being so large that the right side of the heart physically cannot pump blood past it. The patient is minutes away from a catastrophic event.
Given that, why would you skip the CTPA? Don't you need that confirmation?
The priority shifts from confirmation to pure life support. A patient in shock can't be safely moved to a scanner. The transport time could be fatal.
So what do you do instead?
You do an immediate bedside echocardiogram.
So the echo is fast. It's right there. What are you looking for?
You're looking for signs of acute right ventricular strain, evidence that the right side of the heart is just being overwhelmed. If you see that, you assume it's a massive PE, and you start treatment immediately. Patient stability dictates everything.
Okay, so stability is the cornerstone. Let's switch to the other side, that pivot point, path 2. The score is low, 4 or less. This is where the D-dimer test comes in.
Right. For a low-risk patient, you really want to avoid unnecessary radiation from a CTPA.
The cost, the exposure.
Exactly. And that's where the D-dimer test is so useful. It's a gatekeeper.
Can you just quickly break down what a D-dimer actually measures?
It's a blood test. It detects these tiny protein fragments that get released when a blood clot is being broken down by the body.
So if there's a big active clot, the level will be high.
The level will be elevated, yes.
Yeah.
And the key here is the test's high negative predictive value.
Meaning if it's negative, you can trust it.
For a low-risk patient, someone with a Wells score of 4 or less, a negative D-dimer is incredibly reliable. It basically confirms your low suspicion.
So in path 2, there are really only 2 outcomes. Let's start with the first. The D-dimer comes back positive.
If it's positive, even though the Wells score was low, that's enough suspicion. You can't safely rule out a PE. The protocol says you have to proceed to the CTPA for a definitive look.
Okay, so a positive test pushes you over the edge into imaging.
It does. But the second outcome, the one you're hoping for in a low-risk patient, is a negative D-dimer.
And what happens then?
This is the elegance of the system. If the clinical risk is low and the D-dimer is negative, PE is excluded. The workup stops right there.
Wow. So you've avoided the time, the cost, the radiation, all based on a point system and a simple blood test.
It's remarkably efficient. The flow is crystal clear. Wells score sets the initial risk, and that determines if you need immediate imaging or if D-dimer can safely stop the process.
Okay, let's move on to treatment. Let's say the CTPA is positive, or the bedside echo confirmed a massive clot. What's the protocol, starting with the stable patient?
For a stable patient, the standard of care is immediate anticoagulation. And the purpose here isn't to dissolve the clot.
Right, it's to prevent it from getting bigger.
And to stop any new clots from forming. Exactly.
Yeah, and what does that treatment usually look like?
Often it starts with something like low molecular weight heparin, enoxaparin is a common one. Then for long-term management, they're transitioned to a direct oral anticoagulant, a DOAC.
Like a Pixaban or rivaroxaban.
That's right.
And why that transition? What's the big advantage of the DOACs?
They're just much more convenient and safer for outpatient use. Fixed dosing, no need for constant blood monitoring like with older drugs.
But we still hear about unfractionated heparin, UFH. When does that get used?
That's a great distinction. UFH is usually reserved for 2 situations. First, patients with really bad renal impairment.
Okay.
And second, if the patient is unstable, or if you think you might need to do a procedure soon.
Why is UFH better for instability?
Because it has a very short half-life. You can turn its effects on and off much more quickly and easily if there's a bleeding complication or if they suddenly need surgery. It gives you more control in a crisis.
That makes sense. The higher the risk, the shorter the leash on the drug. But what if the patient is not just unstable, but critically unstable, the massive PE we talked about?
Right. This is the crisis protocol. Standard anticoagulation is not enough. The clot itself is the immediate threat.
So you have to be more aggressive.
You have to be much more aggressive. The protocol mandates thrombolysis. The source material specifies Alteplus, 100 milligrams over 2 hours, with the goal of rapidly dissolving that clot.
Thrombolysis is a powerful tool, but it carries massive risks. What's the trade-off you're making there?
The trade-off is life versus a potential catastrophe. You're balancing the immediate risk of death from the PE against the very real risk of a major bleed, most notably an intracranial hemorrhage.
A bleed in the brain.
A bleed in the brain. You're trying to save the heart, but you're putting the brain at risk.
Yeah.
It's only for situations where the PE is the more immediate threat.
It really emphasizes how the entire treatment plan hinges on the patient's stability.
Absolutely. The clinical picture is everything.
And if thrombolysis fails, or if the patient can't get it for some reason, the sources mention the final mechanical options.
Those are the last resorts. First is catheter-directed thrombolysis, where you thread a catheter right up to the clot and deliver a smaller dose of the drug directly.
To limit the systemic bleeding risk.
Exactly. And the final, most drastic measure.
Surgical embolectomy.
Surgical embolectomy, physically going in and removing the clot. A huge operation reserved for when everything else has failed.
We've really covered the whole system, from scoring to surgery. The Wells score is this initial calculator efficiently routing patients to either a CTPA or the D-dimer gatekeeper, and then the treatment ladder follows from there.
It does. And I think what's so fascinating here, and something for you to really consider, is how a simple 7-factor point system can so clearly differentiate between a patient who is in a true life or death crisis and one who can be managed safely with far less intervention.
Yeah.
That ability to immediately route an unstable patient to life-saving therapy while at the same time protecting a low-risk patient from unnecessary testing.
Yeah.
That is the core ingenuity of these systems. It's a power to find a safe way to just stop the process entirely, all thanks to a simple blood test. That's truly remarkable.